There.
Hello. Hi
How
there.
are you?
Hello, hello. My name is Marie. I am one of the nurse practitioners here at Planned Parenthood. Super excited today for the topic that we have. Before I introduce our amazing guest speaker today, Dr. Heather Quaile, I'm just going to give a couple of disclaimers. So today we are talking about when sex isn't doing it for you, dealing with sexual dysfunction. Um, Obviously, sexual dysfunction covers so many different topics, and for just the concept of time today, we are just going to be focusing on low libido. Okay, and even more specifically, we are going to be focusing on cis women. So people with vulvas. Obviously, this low libido, that just transcends all genders, but for the concept of time today, again, we are going to just be focusing on low libido for cis women. So again, my name is Marie Peters. My pronouns are she, hers, and hers. And I'm going to go ahead and pass it over to Dr. Heather Quayle.
I am so honored to be here. Thanks, Marie, for having me. I'm Dr. Heather Quaile. My pronouns also are she, her, and hers. I'm a women's health nurse practitioner practicing for the last 22 years, kind of all over the map, but Georgia now is home for me. And I specialize in sexual dysfunction as well as trauma, especially trauma-informed care. I have my own private practice, the Show Center, as well as do a lot of work around human trafficking, help to start a human trafficking center out here in the Georgia area. I'm an asex sexuality counselor, so Marie and I are going to dive in a little bit about that and where that kind of goes with this whole biopsychosocial approach, which you'll probably hear us mention a few times with talking about low libido.
Wonderful. Well, so happy to have you, Heather. So let's go ahead and just get started. Tell us, Dr. Quayle, what is low libido? What is the medical term, and what does this look like for people?
So it's probably one of the most common things that I see in my practice. And when I say common, though, it's very interesting. We kind of talked about this earlier today before Marie and I even jumped on to do a live with you. It's becoming more common because it's wonderful that people are getting out on Instagram and they're encouraging people to talk about it. But before, we were locked in our silos and taboos, and you couldn't talk about these things. So what low libido is from a medical standpoint is called HSDD, hypoactive sexual desire disorder, or simply in layman's terms, low libido. And I've pulled some statistics here that it says it affects somewhere, according to the national NAMS, North American Menopause Society, they say about 8.9% of people between the ages of 18 and 44 and 12.3% of women between 45 to 64. I'm going to beg to differ that a little bit, and we kind of chatted about it. I've also read like 26.7% of the perimenopausal patients have some sort of low libido, and about 52.4% of menopausal patients. So again, as you can see, stats are all over the map, and I think it really has to do with women don't feel comfortable talking about this. So very excited to kind of get out here and kind of break down taboos and talk a little bit more. But to answer the question as well, hypoactive sexual desire disorder means that the patient is having low libido. It can be either coming from a male standpoint, a female standpoint, a trans patient. It goes all across genders, but again, we're looking more at women. But this is not really an issue unless it's something that specifically bothers you. So if it is something bothersome and it affects the relationship that you're in, then it is a medical concern.
No, absolutely. And I love mentioning that because we're going to definitely launch into different types of treatments, right? We have options, medication-wise and otherwise non-medication options. But really, you are only a candidate or if you need to even pursue treatment if this is bothersome to you. If it is something that, at one point in time, perhaps you had a level of sexual desire that was acceptable to you, and maybe there's been a decrease that is no longer acceptable. That is when, really, at this point, we can start talking about different treatment options. But absolutely, like Dr. Quayle said, for someone who is unbothered by their level of sexual desire, I think we all just need to normalize that there is no right or wrong amount, right? There's no correct amount of times that someone should be having sex per week, per month, per year. So I think just normalizing that in general is great. So, Dr. Quayle, can you speak a little bit about some people that are tuned in today maybe know some of the different subsets when it comes to hypoactive sexual desire disorder. So, there's acquired, there's generalized, lifelong. Can you kind of speak a little bit to the different subsets?
Yes, absolutely. So it kind of, and I also will call it situational. So acquired means that it kind of happened over an event potentially. So did you go into menopause? Are you in perimenopause? Are you having low desire because it's painful to have sex? Another thing we don't like to talk about, and this can be a whole other Instagram for hours, is a lot of times hypoactive sexual desire or low libido happens because it hurts when you have sex. And so that's going to lead to that. So something that's kind of acquired over time. And then, of course, is it something that is more of a generalized situation? Like, has it been there forever? Is it something that maybe you may be on the asexual gamut? Are those kind of things interplaying in there? Is there a history of trauma? Is there a history of rape, sexual assault? What do all those pieces look like, and what is that doing to affect this state of feeling low libido?
Absolutely. And something else to even mention too is body image, right? I think that that's huge. And to mention that perhaps, and that's where discussing with patients just healthy lifestyles in general, but also just factoring in, like, if you're not feeling great about yourself, maybe in your body image, that can absolutely play into that, as well.
Because we're also talking about women, it's so important to point out that we are so stigmatized in society. We have to look a certain way, be a certain way, smell a certain way, act a certain way. I could just go on and on and on. And so when we don't fit the mold of how society wants us, we may feel overweight, or we're on our cycle, or things of that nature that are taboos according to having sex, like, oh, fat people don't have sex, or you can't have sex on your period. These are all horrible things that society has done for women. And so those will lead to situational low desire issues.
Absolutely. Absolutely. So this next question, we could also talk for a very long time about this, but what are the causes of low libido? To just kind of speak a little bit more specifically here, what are some medical conditions that you have seen patients come into your health center, experiencing that do have a correlation with low desire?
Absolutely. So again, I come from a trauma perspective. So one of the first things I ask people, and I'll usually do it in their intakes, because sometimes it's very uncomfortable, especially for providers that may be in primary care settings. One of the biggest things I try to tell them is ask your patients, what does desire look like? What are you having sex? Is it good sex? Are you happy with that? Are you orgasming? But they may not feel comfortable saying that to their patients. Part of the reason why women aren't talking about is because their providers don't ask. And the reason providers don't ask is because we're not taught this. And so I always say, bring it in on the intake. But some of the medical conditions that I see, again, I'll bring in the trauma piece, especially on intake. Like, is there any kind of history of any past abuse? That's kind of where my first question goes. Then the next big, huge area that I see a lot of problems with libido is when our hormones are just all out of whack, and not just for that perimenopause and menopausal woman. Of course, yes, for that, but also in the patient that may be on birth control pill. I'm never going to bash a birth control pill, because I think they have their place for certain things. But from a perspective of a sexual medicine provider, birth control pills can wreak a lot of havoc and cause low libido. And a lot of times OBGYNs just will put people on it, but they won't tell them that their low libido could be because of their birth control pill. So I kind of want to put that out there immediately, that is a big reason. And then, of course, other meds you're on. We have a lot of people in our society now looking at doing that are on SSRIs, especially like your Lexapros and your Zolofts and your Prozac. All of those have an effect on libido as well as on weight gain. So those two pieces kind of going in hand are also going to wreak havoc on your state of feeling like you're in the mood and that you want to participate in relations.
Yeah, absolutely. And you mentioned SSRIs, so antidepressants. Any other medications that you commonly see that might have a link as well?
So some of the other ones that I'll see is for some, occasionally you'll get some hypertensive medicines that can kind of interplay with that. A lot of patients that have other kind of comorbidities and they're on multiple different medicines, I always really try to take a look at everything they're on. But I do find the SSRIs to be a big, huge culprit, and birth control pills, and especially when hormones aren't optimized. We often don't think of this beautiful hormone called testosterone. We are like, oh, testosterone, it's a male hormone. Females don't have it. I'm going to kind of kibosh that right now and say we have greater the amount of testosterone receptors than we do estrogen as females. And so when our testosterone levels start to deplete in perimenopause, menopause timeframe, that too is going to affect things as well.
Absolutely. Now, so we've talked about, what low libido is. We've talked a little bit about what can cause it. What are ways that we can help treat and manage low libido? So, and again, we've already mentioned that treatment is for anyone that this is bothersome for, right?
Correct.
What are some examples of some medications that exist that can help with low libido?
So let's think about this, because I love to put this out. ISHWISH, the International Society for the Study of Women's Sexual Health, is probably one of my absolute favorite societies, has a beautiful slide that says, how many treatments are there for men for not necessarily low desire, but erectile dysfunction and sexual concerns and problems. There's probably like 36, 40 different medicines for males, and two medicines that are for females. And I will tell you, the first one didn't come out until, I'm going to get this wrong when I say flibanserin. I want to say it was around that 2014, 15. I could be wrong on that. I may have just botched that. I'm sure my flibanserin people are going to hear this and be like, Heather, you should know this, but it's taken that long to get a drug out there. So there are two medicines that are FDA approved for low libido. One of them being flibanserin. You may have heard it called Addyi, or the little pink pill, and it's a pill that you'll take every single day. And usually what I tell people about this pill, I do have quite a bit of patients on it, but usually you're going to see some sort of results of it helping with increasing desire, increasing what we call sexually satisfying events. And usually that's going to happen about 8 to 12 weeks on the meds. The other thing I tell patients is if you ask for a prescription of flibanserin and you want to try it, if it doesn't work after 12 weeks, it's not going to work for you. So you're not out with trying something for years and years and years. The second medicine that's out there is bremelanotide, or the trade name is Vyleesi, and that is an injectable shot. And that is something that patients deliver about 30 to 45 minutes prior to having sexual relations. And I always call it like sexual relations because I'm never going to want to call it intercourse. I never want to assume that sex is penis and vagina intercourse, even though we're talking about females today, because I think one of the things we need to talk about is, what is a sexually satisfying event? I didn't mean to go on a tangent, but it can be anything from touching, oral, vibrations, self-stimulation. It does not have to be a penis entering a vagina for a woman to become stimulated. And that too is its own caveat, because most women are not experience a form of orgasm through penis and vagina intercourse. The clitoris is the key. So that was a tangent. But anyway, back to bremelanotide. That's a self-administer injection, and that's 30 to 45 minutes prior to intercourse. Then, of course, there's this beautiful thing called testosterone. It's off-label. We don't have anything for females, but we use it quite successfully in a very small amount, about 1/10 of the male dose, and that we use that quite a bit to help with helping with libido issues. And again, these are all prescriptions if this is something that is bothersome to you. If it's not something that's bothersome to you, but your libido has decreased, but it's not an issue in your relationship, or it's not an issue if it's a self-stimulation and you're not partnered, that's fine. You don't have to go down the road with any of these medications.
That's great. And I love how there's also options in terms of what fits your lifestyle, right? Maybe because the injection is kind of obviously used like as needed, right? Versus you have Addyi that's taken daily, and some people, really might prefer a daily option versus just, having it on hand. So I think that's great. And Another question for you is, I oftentimes have patients where they'll come in, we'll be discussing low libido, we'll be discussing options, and a patient may say, I don't want to take a medication. Maybe this person is on so many medications already, and so I don't want to add something to the regimen, or maybe it's someone who's not on any medications at all and really happy with that. So what other options do people have outside of just taking a pill or having the injection?
So one of the things, again, I'm going to go back to the issue of pain, because is pain the issue? You wanted to kind of do a good workup on pain. There are some over-the-counter things that you can use if it's a vaginal dryness issue. Of course, I'm a big proponent for vaginal estrogen, but if a patient doesn't want that or they're nervous about taking that, of course, there are other options, DHEA and hyaluronic acid and different things over the counter, and just kind of bringing lubrication and it back into the female parts, the vulva, the vagina, may also help with just arousal and helping with libido. If they don't want to do anything medication at all, then that's kind of where I wear my counselor hat a little bit more, because again, you heard me use that word, biopsychosocial. I don't feel like I can do my job as a sex medicine provider without having different parts and pieces. And for me, it's usually my right hand's a pelvic floor physical therapist that helps with lots of pain issues. And my left hand is sex counselor. And as it gets deeper into other things, especially deeper traumas and issues, then a sex therapist. And I kind of wear that biomedical hat where there are medications. But for patients that don't want to take a medication, looking at things, where is it coming from, the counseling piece? Let's dive into the relationship. Where are their issues? Is there communication? Again, you heard me say earlier, we're so stigmatized in society as females. And so we don't even talk, we can barely talk to our providers. So can we talk to our partner? Can we tell them what feels good or what's not feeling good or where the flaws are? So that again is where sex counseling really jumps in to kind of help for people that may not want to take any kind of medications.
I love that. Now, I recommend, well, first of all, pelvic floor physical therapy all day long. So amazing. And I do also recommend sex counseling, but I oftentimes have patients that kind of look at me and go, okay, what am I getting myself into? What is this actually going to look like for
Yeah.
me, my partner, my partners? And how's it going to benefit me? So just would love to kind of pick your brain as, you being a sex counselor, just what exactly those sessions can look like.
Okay. So I'm glad you asked that. The first thing I'm going to debunk right away is that when you go see a sex counselor, sex therapist, you're not having sex in an office and them watching you, because I hear it all the time. Oh my gosh, do I have to have sex? Do I have to show them a video? Is this a live thing? Is there
no.
No, 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 and no. It's very much like a therapy session. You can go in by yourself. You can go in with your partner. You can do a combination of your partner goes in on one visit, you go in on one visit by yourself individually, and then you come together as a couple. And a lot of it is talk therapy. They're going to talk to you about family history of things, your religious background. Unfortunately, there's a lot of religion that has taboos around sex and what you grew up with in your upbringing. They're going to talk to you about things. What does your family dynamics look like? Were you only talked about abstinence only, and if you had sex, you were going to get pregnant, and they were all these horrible things, and so you're fearful around sex? They're going to talk to you about what it looks like with partners. Is there a history of trauma? Is your partner in pain? When you have sex partnered and it's painful, oftentimes it'll affect the non-pained partner because they don't want to hurt their loved one. So those are things, it's a lot of talk therapy where they're going to ask you lots of questions and then help you to communicate with your partner.
That's amazing. And yes, because there's oftentimes kind of maybe like a mismatched desire, right? In terms of maybe one partner is feeling one way and another is feeling a different way. And it just kind of probably a lot of just how can we communicate this
Yeah.
effectively?
And even mismatched desire. I think that's a really good thing, is that maybe one partner wants sex more than the other. And I'm never going to say it's always the male that wants more in a heterosexual relationships, because it oftentimes could be the female. But kind of helping work through strategies. And I hate to say scheduling sex, but sometimes when you're going through lots of problems, some of the best things to do initially is to kind of schedule that intimate time. Like, we're going to go have a date night. We're going to have some wine. We're going to chat. We're going to do sensual touching. We may take a bath together, and kind of get yourselves in the mood again, to maybe help the partner that is kind of having that mismatched desire, or may not be feeling in the mood or feeling good about themselves.
Right, right. And especially for partners that potentially it's been a long lasting relationship, I think that we can all normalize, how those different interventions can be helpful. And so one other thing I did want to mention, is as we're just kind of talking about management and different treatment options, is, at Planned Parenthood, we do offer telehealth too. And so I think that that's really important as well. Just, I know we're in the age of telehealth. And just wanted to mention too that we're kind of talking about how some people may not find this to be very comfortable to talk about in general, but maybe how telehealth can be something that, you're in the comfort of your own home. Now, of course, if you are having pain with sex, if you're having other physical symptoms, then, that would warrant an exam just to, make
I,
sure.
I think you hit on something, that sometimes it's easier to do that telehealth because it's easier to look at someone through a video camera than face to face. And then maybe starting there for someone who's so terrified to come in and talk about it. And it's also a way sometimes, if you have a partner that doesn't want to do it, no pun intended, but a partner that doesn't want to come in person, a telehealth is a great way. And then if you feel like, yeah, maybe you need some vaginal estrogen, or I need to look at your tissues, then you've kind of broken the ice and they're more comfortable coming in for an actual physical visit.
Yeah, yeah. So I agree, completely agree. So I see that we've hit 20 minutes of chatting, but
Knew that was going to fly.
we knew it. So next, I would love to just open it up for questions in the chat. So if anyone has any questions, go ahead and enter that on in, and we are happy to answer any questions that anyone may have. We did a lot about 10 minutes for questions, so happy to kind of, jump on into that.
I did see one on here. I actually can see it on my end. We didn't know. And it asked, have I had any luck or experience prescribing Addyi or Vyleesi for the Medicaid patient? Unfortunately, to answer that question, no. I have not had the greatest luck on insurance just in general for it. It's not crazy expensive, but I know for the Medicaid patient, $99 a month may be expensive. But what I often will tell my patients is usually, at least I think it's on both of them, that if you order it as a 90-day supply, again, patients are going to know in that 90 days if it works. And oftentimes if you order it as a 90-day supply, I believe the first month ends up coming out to be free. Do you know that, Marie?
That does sound right. Yes.
Yeah.
Mm-hmm.
And so usually I'll say, let me try to write you a 90-day supply. You may be out about $200, but $200 is so small in the whole big picture if you're talking about a very fractured relationship because of libido issues that you're really wanting to fix. I know it's very cost prohibitive for some, but again, if it works, a lot of patients are very okay with that cost.
Right. Quality of life just absolutely increasing. Are you able to see any other
Let me see if I see any. I don't see any more in here. That was the only one.
That was a great question, because cost just is of course a factor, right? And so, next, you spoke a little bit about your work when it comes to the nonprofit that you work with when it comes to sex trafficking, and a little bit on trauma. Maybe speak a little bit about how that can kind of weave its way into this conversation.
Absolutely. So by background too, I'm a sexual assault nurse examiner. So I've been taking care of patients that have been victims of rape, doing rape, sexual assault exams for several years now. And that's kind of how my work in trafficking evolved. And I was able to start a human trafficking center for emergency stabilization for teens here in Georgia. My age group in my facility, Wellspring Living is the name, and I can give the, I think they're at Wellspring Living. Is their Instagram. Wonderful organization, have many different layers, but my center is emergency stabilization for teen youth, 12 to 17. But we also have adult trafficking services as well that we offer through them. And there absolutely is a layer with trauma from a multitude of standpoints. If there's been a history of trauma, such as a rape, a sexual assault, especially being trafficked over and over and over again, that really does downplay any kind of form of intimacy for a lot of people. And so when I often see a libido issue, like I said, one of the first questions I ask in a non-confrontational way to ask it is on your intake paperwork, is put it in there. Has there been a history of trauma? Has there been an area that you may want to talk about where there's been non-consensual sex? Very maybe easy ways to kind of put it so that you know that they're comfortable talking about it and that they may want you to mention it in their exam. So that plays in it too. But I also think it's important to talk about from a partner standpoint, and again, across all genders, it doesn't matter if you're male or female. If you're with someone who has a history of a trauma, especially a rape, a sexual assault, it's going to be very different for you being the partner that's trying to be intimate with that person. And I feel like there needs to be way more resources out there for the partner who's with somebody who's experienced either intimate partner violence, trauma, trafficking, things of that nature, because it really does affect the libido. And oftentimes that partner really loves that person, but doesn't know how to be the person to kind of care for them in the middle of being intimate, maybe because they feel like intimacy is an act where you're maybe showing love, but it may not look that way from the trauma person.
No, thank you for sharing. It's been great to hear just your perspectives, not only from the sexual trauma, your experience there, but then also sex counseling and just kind of looping it all together, how this is all just so multifactorial, and so important. Why, you mentioned earlier the biopsychosocial approach, right? Why that's just so critical. So I am not actually seeing any other comments or questions at this time. Are you seeing anything on your end, Heather?
Roll one more time through. No, I am not seeing anything on our end. So yeah, so as we wrap up, we would definitely want to tell you all how to find us and all that stuff.
Yes. Again, my name is Marie Peters, one of the nurse practitioners at Planned Parenthood. We would love to see you. If you heard anything here today that really resonated with you and said, that's me, that is what I'm experiencing. We have space for you, and our providers are all trained when it comes to sexual dysfunction, and that involves, all things sexual dysfunction, including low libido. And if there is something that perhaps, we can start, and maybe we try a medication, maybe it doesn't work, we have other resources and referrals that we can provide when it comes to more specialized sexual medicine providers in the DMV area. So please come on over. Like I said, we also we offer telehealth, we offer in person. And then Dr. Quaile, you can speak to your practice in Georgia.
So I have a practice in Georgia. That's where I'm licensed, but I'm also licensed in a couple other states, but I see people in person in Georgia. My center is called the SHOW Center, the Sexual Health Optimization and Wellness Center. I'm definitely an acronym girl, and you can find me on Instagram at Show Center, SHOW Center, Dr. Q. And then I'm just www.theshowcenter.com. And then again, with my trafficking work, that is at Wellspring Living. And you can kind of look at them, and it's a wonderful nonprofit as well.
Amazing, amazing. Well, I just want to thank everyone who joined today and for the engagement that we had. This is a topic that is near dear to both of our hearts, and I feel like it is something that is it's common. As we discussed just how common it is, but it's not commonly talked about. And so I feel like today, just really happy we created the space to be able to just open this discussion and have some of these chats. And then Heather, I just want to thank you for joining us, virtually all the way from Georgia. Today has been really great. It's been excellent to just hear your expertise.
And thank you so much for having me. Very honored to be a part of this. And hopefully you and I can get the word out there more, that patients start asking.
Absolutely. All right. Well, thanks everyone for joining. We're going to go ahead and wrap up, and I hope everyone has a great rest of their day.
Bye, everyone.
Heather.